Asthma is the most common chronic disease worldwide. More than 339 million people are living with asthma. Over 80% of asthma-related deaths occur in lower middle-income countries. Asthma is underdiagnosed and undertreated. It creates substantial burden to individuals and families and often restricts individuals' activities for a lifetime. Although asthma cannot be cured, appropriate management can control the disease and enable people to enjoy a good quality of life. If left untreated, there's a greater risk for long-term effects and severe complications. These long-term effects include airways remodeling, hospitalization, asthma attack, and respiratory failure. Despite affecting billions of people, there are various myths and misconceptions concerning asthma that prevent asthma patients from enjoying optimal benefit from the major advances in the management of this condition. In this series, we provide a clinically focused overview of asthma, emerging therapies, controversies, and uncertainties in asthma management from the experts.
Hello, I'm Sujit Rajan, pulmonologist at the Bombay Hospital Institute of Medical Sciences and Bhatia Hospital in Mumbai, and I welcome you all to episode 5 of Healthcare Superstars. We have completed 2 series within the respiratory segment with 2 episodes each. One series on IPF and ILD and the other on COPD. In episode 5, we now move to another important concern area within respiratory medicine for a long time, and that is asthma. In today's episode, we shall be addressing the much debated issue of challenges in primary healthcare management of asthma, with some interesting case scenarios which we will discuss. But before I move forward to inviting and introducing our speakers to you, I would like to first thank our collaborators, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AthmaPath from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. Our first guest speaker for today is Dr. Miguel Roman Rodriguez. Miguel is professor at the Balearic University School of Medicine. He's a family physician at the Health Research Institute of the Balearic Islands in Palma de Mallorca in Spain. Miguel has also been the past president of the International Primary Care Respiratory Group, IPCRG, and a past member of the board of directors of the IPCRG. He is a 5-star doctor in a sense and has been the winner of the Wonka Europe Award of Excellence in Healthcare. He's also a member of the editorial board of the Primary Care Respiratory Medicine Journal and has been involved in guideline development and actively collaborating in COPD strategic national plans in Spain. He has over 40 publications on obstructive airway disease. Our second guest is Dr. John Hoffney. John is Associate Director, Clinical Research and Development at the NHS Greater Glasgow and Clyde. He's also a Senior Research Fellow at the Centre of Academic Primary Care, University of Aberdeen, and an honorary Senior Lecturer at the University of Glasgow. John has been the past president of the International Primary Care Respiratory Group. He has over 20 years lead in varieties of educational programs for both primary care and secondary care clinicians. John has over 500 presentations at PCRS, IPCRG, BTS, ERS, ATS, and the ACCP meetings. He's a regular trainer for undergraduate training at the University of Glasgow, University of Aberdeen, and has over 74 peer-reviewed publications. So I welcome both John and Miguel to episode 5 that we present today. So with that introduction to both Dr. John Hoffney and Dr. Miguel, I welcome you all both today to episode 5 and look forward to the deliberations we're going to have today on your two interesting cases and a short one by me. So over to you, Miguel, for your first case.
So this is a case about differential diagnosis in asthma, because sometimes we feel that everything is done and asthma is there and we are treating, but sometimes we are losing some points and there are things that we are misunderstanding or we are, not getting to the point. This is my declaration of interest. A lot of companies there from all over the world. So, of course, we are now in the pandemic situation and we have to make a telephone consultation, and that adds another problem to our day-to-day life and our day-to-day practicing. So today we have a telephone consultation in our agenda, in our list of patients, and we see that Sarah is there waiting for us to call her. She's a 32 years old woman. She's teacher. She teaches maths in Mallorca here. I live in Mallorca in a high school. And she's been suffering asthma from her early childhood. She's also allergic, no other respiratory or general conditions, or not anything. And now we see in our files that she's prescribed on ICS LABA, corticosteroids, inhaled corticosteroids, and long-acting bronchodilators for maintenance therapy, and then salbutamol as needed for relief and for rescue medication. And she asked for asthma review remote consultation. So we take a look at the files and we can see that following GINA guidelines or all guidelines in the world, she was very well diagnosed with asthma a long time ago. We can see in our files her spirometry with a great hyperresponsiveness, bronchodilator test, a positive bronchodilator test that can confirm the diagnosis of asthma. And this was made a long time ago, years ago, when she was early in the adolescent, about 10 years old. We keep on seeing the files and we see that asthma has not been the same for all her life, and different severity asthma periods has happened. In the childhood, she was in regular maintenance therapy. Maybe her parents were making her to make the right treatment, but then adolescence came and she gave up the treatment. She was not visiting us, but finally nothing happened. So she had no flare-ups. It seems like her asthma was well controlled with no medication, and this sometimes happens. Still asthma is there, but sometimes they adapt to short to small symptoms and they have no flare-ups. So she was living with her asthma like that. But 2 years ago, she began to play sports. She began to jog, and then he began to suffer many exacerbations. And she came back to us to tell us, "Doctor, I have been for nearly 10 years with no asthma symptoms, very well with my asthma, some salbutamol once a month, twice a month, and that was all. And now I'm suffering a lot from asthma and I cannot make my exercise in the way I should like." So we can see that something is happening and we have to make something on that. So we take the phone, we call her, and we make the anamnesis, we make the questions to her to see what's happening. And this is what she told us. No night awakenings, only breathlessness during exercise, no more breathlessness during the day, not in class, not when she's making her normal life. But he has increased the control of medication. She's in budesonide and formoterol, and she has doubled the dose. She's now twice a day, 2 puffs in the morning and 2 puffs by night, according to the personal asthma action plan that we gave to her 2 or 3 months ago when she consulted for this situation, this changing situation.
So Miguel, I just had a question here. You mentioned that she was using a salbutamol inhaler when she gets breathless during exercise. Is that what you would recommend these days for relief in exercise? Or there has been some talk about using steroid even for that. What's your view there?
Yeah, the problem sometimes it's better to put some corticosteroids for as reliever, because then you are getting some anti-inflammatory drug on top of the bronchodilation. But in
Right.
this case, you can see here that she was already taking twice a day her controller medication. The adherence was good. So
Right.
maybe an extra salbutamol, maybe an extra controller could also work. But then we decided to put on salbutamol alone for the.
Sujit, I agree with Miguel on this point.
Sure.
Although it's important to make sure the patient has enough inhaled corticosteroid, in this case, she's done exactly the right thing by following her personal asthma action plan and doubling her controller medication. So it's entirely appropriate to use the salbutamol here, given that she's got a good dose of baseline inhaled corticosteroid.
Sure. Thanks for that, John. Thank you. Please, Miguel, continue.
And I put here the ACT because, of course, in a telephone consultation, we cannot make an ACT to the patient because she has to make it in the paper or maybe online. But I wanted to put it here because normally when I'm in the consultation with asthmatic patients in front of me in face-to-face consultation, I always give them the ACT to complete. And I think this is a very important point because then we speak the same language. It's important that when we measure the control of the patient, we are speaking the same language. And it's not the same to say, how are you? I'm fine, no symptoms. When we have it in the paper with a number, with the scoring, I think it's better for the understanding of all the professionals around her asthma.
Do you think this is really, because I see a lot of respiratory physicians not using the ACT, and you're a primary care physician, so that's fantastic. Do you see huge value in getting those scores, Miguel?
Absolutely, because as I'm telling you, the right way to measure it, because then we have an objective measurement, not only how are you, that sometimes, and of course it fails, and not to say, but if you repeat it on time, you can see the evolution of the asthma. And when others professionals go, for example, for emergency department, or when they go to the neurologist or to the specialist, they can see a number, something that had happened in the last times, in the last years or months. So I think it's very important to promote the use of this kind of questionnaire, maybe this one or another one, but promote the use of questionnaires to control asthma. Some people is overusing SAVA with no control medication. And of course, that could be another question apart from the questionnaire. But I think we always have to make this question: how many salbutamol puffs or how many salbutamol cans are you using by month, by year?
Sure. No, I think it's a great take home for both respiratory physicians and for physicians who see a lot of asthma. It's a superb message that you've driven in here. Please continue, Miguel.
So the diagnosis is that Sarah has an uncontrolled asthma. It's clear that it's 18, less than 20 in the questionnaire is an uncontrolled asthma. And as we can see, something is happening. Of course, it's not a bad situation because day-to-day life is okay, but the sports is very important for her now, and we see that something is happening. So this is a paper from John, and then another people from IPCRG. In IPCRG, we have another desktop helper on this called Simples. When you have an uncontrolled patient, you have to do something. And these are all the things that can lead the patient to a out of control situation. And of course, in this case, maybe we have to go for incorrect diagnosis because we have the diagnosis made a lot of time ago in the past. Nothing happened, and now something is happening, and we have to interview the patient more deeply to see what is happening. Okay, so we know that to confirm asthma diagnosis, we have to see symptoms, variable, maybe exercise, viral infection, or allergens can promote the crisis or the symptomatic periods. It can appear early from childhood. Maybe it can appear also in older people, but it's normal to appear in childhood. And it is accompanied by crisis of bronchospasm. That's asthma, symptomatic asthma, suspicion of asthma. And then we have to make a spirometry to confirm the diagnosis. And of course, sometimes a spirometry won't give us the diagnosis and we have to make more tests, or we have to make variability tests with peak flow, or we have to make FeNO or something like that. But if we have a reversibility test, we have the correct asthma diagnosis in front of these symptoms. And this was done with Sarah in the past. Yeah. So in summary, in Sarah, we have a proper asthma diagnosis made in the childhood. She has been free of symptoms and no need of maintenance medication for years. But 2 years ago, she increased the use of rescue medication, especially during exercise. She hasn't responded to increasing control of medication, as we have told us for her self-management plan. And we don't find any of these conditions that could promote a lack of control, like smoking, new medication as beta blockers or something like that, no new allergens exposure. She has no move to another home or a new boyfriend or something like that, or a cat or a dog. And the medication adherence is good because we know that she makes the medication, she's taking it from the pharmacy, and we know that she has a very good inhaler technique because we have checked that in the past. So, what's the problem? Maybe here we have to take a look at this in red, the no response to increased control medication, because asthma normally responds very well to inhaled corticosteroids. Not in severe asthma cases, but as you can see here, it's not a severe asthma because she has no worsening by night, she's not flare-ups, but she's still having this problem with the exercise that is not responding to control medication. So this is not a normal increasing severity case of asthma. Something more is happening. So sometimes we have to look for another thing. So let's go back to Sarah and the telephone and ask her more depthly what is happening. And then in the interview, we ask for other symptoms. And then you can see these symptoms there that are clearly giving us an idea of something that could happen in the upper airways. If you see here, the symptoms are hoarse voice changes. She reacts to this, telling that she's a teacher, and many teachers, as herself, they have problems because they speak too much in the classroom, and then they have this hoarse voice. And so she adapts her situation to this, and she thinks that this is the cause. But we have a clear diagnosis when you have this problem. It's vocal cord dysfunction. And maybe this is the problem with Sarah. When we speak, the cords, our vocal cords, they nearly close at all, and they vibrate, okay, to make the voice, to produce the voice. But when we take air, when we inspire and the air goes on, then the cords open widely to allow the air to come in. But in this situation, in this vocal cord dysfunction, related to some triggers that can be very variable, and exercise is one of them, the vocal cords, they remain closed when we try to get air in. And that's the situation that promotes a kind of asthma symptoms, more inspiratory than expiratory airflow obstruction, and a distress and a breathlessness that is not getting better with the medication. How we diagnose vocal cord dysfunction? Mostly we can conduct an spirometry in primary care. I don't know in your countries, but in Spain we have availability of spirometry in every primary care practice. It's more or less used. Somewhere they use it more, somewhere they use it less. But we have this available. And then with an spirometry, we make the inspiratory curve. Here you can see that the inspiratory curve can flat because when the air comes in, okay, the not widening of the vocal cord of the larynx make this cord too flat, okay?
Right.
Of course, this can happen when the situation is happening and not always, because as you remember, Sarah is okay all day long, and this situation is only happening with exercise. That is very typical from this dysfunction. So maybe we need another test to see what is happening. And the confirmatory test, the gold standard for the diagnosis is laryngoscopy. Okay, we made a laryngoscopy, a video laryngoscopy, and we say the patients to take air in and out, and then we can see that these are normal closing cords during inspiration.
Sure. So I see that, Miguel, a lot of these things would be happening when the patient has symptoms, am I right? And so the challenge is to do this in primary care and you say most GPs in Spain have a spirometer. I don't think that's the case all over the world, and maybe not even in the UK. I'm not sure John's thoughts on that. But in the absence of getting that spirometry done, if the patient has no symptoms when they reach the clinic, I guess it's history largely, or do you provoke exercise? What do you do, Miguel?
Yeah, this is not a very, very usual situation.
Sure.
It's a condition that is not very usual, but in some cases like this, we have to be aware that it exists and think of it. And maybe the best option when we think of it is directly make a referral to the ENT, because they will have the choice. But maybe if we have for example, in young people, because it's not recommended in adult people, because you can promote a stroke or a myocardial infarction or so, you can make an exercise test, as you can see in the picture. Okay, this is treadmill that is not available in primary care, but in primary care we have made in children some exercise tests for exercise-induced asthma, and just make the children to go up and down the stairs to promote they have an increase in the health frequency, and then when they're a little bit tired, we make spirometry. So it could be, but if they are older people, we are in a risk of making this in primary care, because we are not in the best situation. If something more is happening, if we can promote another more severe situation with the exercise. But it could be done. But of course, I agree with you that maybe it's better to, if we suspect it, to send directly to the ENT.
So, John, any thoughts in primary care in the UK and Scotland? Obviously, you're restricted by NHS to refer everyone to an ENT surgeon and a laryngoscopy. So, what would your message be to physicians suspecting this condition?
I think the first thing we have to do, Sujit, is recognise that colleagues in different countries have different availability of these kind of tests.
Right.
And one of the reasons we're discussing, the three of us are discussing this diagnosis today, is because we suspect that it's more common than we've previously thought.
Right.
But we can't really prove that unless we go to the point of making a final diagnosis. So we're now suspecting that more people have vocal cord dysfunction than we previously thought. And by talking about it today, we can raise awareness amongst our colleagues to be aware of it. But there are some problems. So one of the features I take from it, just in terms of clinical examination, by phone or in person, is that there's a problem with inspiratory issues rather than expiratory. Now that's quite important, but it's quite a subtle diagnosis, a conversation to have. For instance, the big problem with asthma isn't so much breathing in, it's breathing out. So people who've got uncontrolled asthma are hyperinflated. So just to give you an example of that, if you take a deep breath, and then I tell you to take a deep breath, it's very difficult to do because I can't take a deep breath twice, and therefore I've got an inspiratory problem, as if I have asthma. So we have to differentiate between the vocal cord issue and badly controlled asthma. And actually, this is what the point is really all about. Yes. True exercise-induced asthma, which I would prefer to call exercise-induced bronchospasm, isn't type 2 asthma. It's not to do with eosinophils. The pheno's not high. It responds to bronchodilators. It doesn't need corticosteroids. But the alternative, which is asthma symptoms on exercise in somebody who has poorly controlled asthma, is just normal asthma, and it's being exposed when somebody exercises. So now we've got three different things. We've got poorly controlled asthma that needs to be treated as normal. We've got exercise-induced bronchospasm, and then we've got vocal cord dysfunction, laryngeal spasm, and so on, which is, almost a different condition but coexisting. So we need to be aware of it. You're right. We're not going to get spirometry at the right time in everybody. We're not going to be able to refer everybody to an ENT surgeon for laryngoscopy. But what we're not going to do is just write this off as uncontrolled asthma. We have to recognize it as a separate condition.
Excellent points. Thank you. Thank you, John. And very, very useful clinically as well. Please, Miguel, continue.
Yeah, just an image that it was funny for me because, of course, the laryngospasm must be demonstrated also in the ENT surgery with exercise-induced situation. And this is the photo that I found in the internet of how difficult it should be to make this test in the hospital. Wow. Just because it was funny for me to see the picture. Okay, right. Everything that you need. This is important because, as John says, it's three situations, and maybe to refer for the ENT surgeon, the best way is to get the diagnosis or the suspicion to increase the possibilities of this situation, of this disease. And as you can see, difficulty breathing in, not out, as John very well explained. The peak is a maximum exercise, while in asthma, in exercise-induced bronchospasm, you can see that it happens after the exercise. Okay, you make the exercise, you can do it well, and then the normal situation is that 10 minutes, 15 minutes, when you stop, then you feel your asthma coming. Sure. The tightness in the asthma, of course, is in the chest. And in this situation, in the vocal cord dysfunction, it is more related to the throat. Okay, it recovers very, very quick, and the asthma attack can be more delayed in time, and it can recover in hours. And then, of course, the response to the drugs, because normally, if you put salbutamol in asthma, exercise-induced asthma, it works, and it doesn't work in vocal cord dysfunction. So this is important before we make the suspicion of the diagnosis. So for Sarah, let's go back to Sarah, and we refer then her to the ENT. They made the laryngoscopy, and then they send Sarah back to us with this diagnosis, induced laryngeal obstruction. And we say, oh my God, what is this? I thought it was vocal cord dysfunction. Okay, don't worry, it's the same. Sometimes doctors, we speak different languages to say the same things. So you know more than me. So we have this, and then we have to make any treatment for her. And this is good news because this situation will never put her in danger. She has not hospitalizations for this, and we can go slowly to get the treatment done. And the treatment basically is to avoid triggers, but of course in this case, to avoid exercise, I don't think is a good option for us because she loves it and it's good for her health in general. So in this case, I don't think we can avoid the triggers. Then sometimes, because I haven't said that sometimes this situation is not only promoted by exercise, there are other conditions that can promote this to happen, like anxiety and depression is very much related to psychopathological things, and then the reflux and rhinosinusitis. And you can see here that all these conditions can also make asthma worsen. So this is another problem, because sometimes it's exercise, sometimes it's all of these conditions that promote the vocal cord dysfunction, and these are the same situations that can promote asthma crisis. We can consider inhaled anticholinergic drugs, so ipratropium or something like that, but it's not clear the evidence that this works. Of course, we have to continue with asthma medication, because Sarah is not only suffering from bronchocordial dysfunction, she's suffering from her asthma, and maybe we can go back to one puff twice a day and not increasing the medication, because now we have the problem identify what is happening, but she has to continue with the control medication, of course. And then the most important thing for vocal cord dysfunction, that is the treatment made by the speech therapists. And they make a different kind of exercises with the voice, exercises with the cords, special breathing exercises, and relaxes inhalation, and these techniques that sometimes, and of course, they work.
Fantastic. I mean, yeah, please continue. Yes.
This is the message to take home, okay? So we have always to confirm the asthma diagnosis when we have in front of us an uncontrolled patient. This is the first point. Is it asthma? Is anything else? Vocal cord dysfunction can be easily taken as asthma. We must make the differential diagnosis. Induced laryngeal obstruction can be difficult to distinguish from asthma, and it may coexist also with asthma, like in this case from Sarah. And we can try to get the inspiratory curve of the spirometry, because sometimes we can get the diagnosis from there. And of course, once we have not the possibility to make more tests, the ENT and the speech therapists are needed to get the right diagnosis and the right treatment for this condition.
Oh, fascinating case, Miguel. I'm just thinking, actually, a question to both of you all. I think all three of us see patients, especially younger women, I have noticed, with what we would call functional dyspnea, where they're breathless and we don't feel there's any problem with their lungs or their vocal cords. You think a lot of this could be VCD? And if it isn't VCD, would they be benefited, you think, with a speech therapist? Because I really don't know what to advise them sometimes, because they come in breathless and there's nothing wrong. The spirometry is normal. There's no inspiratory flattening. And they've been given multiple medications by primary care providers looking at, bronchitis, asthma, and the works. What's your thought to deal with? I mean, I call it functional dyspnea, and one of the doctors who was a patient came back and said, no, I know my diagnosis. It's sighing dyspnea. So she found this diagnosis on the internet and said she has sighing dyspnea. Miguel, what's your thought?
Well, absolutely right. There are some people, and I have a colleague from mine, and we started, she's a yoga teacher, okay?
Right.
And we started a randomized control trial in rehabilitation and respiratory rehabilitation in primary care because of her. Because in yoga classes, she thought and she observed that a lot of people, they don't know how to breathe.
Right.
And she said, so sometimes asthma, or we are thinking that it's asthma that is uncontrolled, but it's because people, they haven't learned to correctly breathe. So right. Absolutely what you say.
John, sighing dyspnea, have I given you another diagnosis or?
Yes, so you call it functional dyspnea. We call it dysfunctional breathing. Now, right. Some people have genuinely dysfunctional breathing, which is to do with anxiety and psychological symptoms. But I think this is where we again get into quite a difficult diagnostic area, because as well as having asthma, you might then develop inappropriate breathing. Yes. The first time you suffer symptoms of asthma, the likelihood is you'll panic. And if you panic, your breathing pattern will change and it might make you worse. Similarly, you could have dysfunctional breathing or inappropriate breathing as a result of your vocal cord issue. So then you're compounding a number of different diagnoses. And the problem we've got just now is it's quite difficult to tease them all out, all the different diagnoses in primary care. And any of you who have access to secondary care will know that we're not conducting the kind of exercise laryngoscopy tests at the moment that Miguel showed. I mean, they're probably aerosol generating and therefore won't be allowed. And the hospitals are under such great pressure and are likely to be for the next year or two that we're just going to have to do our best and use our clinical skills. I think the problem is that you can get inappropriate breathing on top of asthma and inappropriate breathing without asthma. And there's a danger that we'll discard everybody who has dysfunctional breathing as something different to asthma, and we won't treat their asthma. So it's going to be a very, very difficult balance for us to find.
No, that's very true. And I think this case had so many messages, and I think primary care physicians will go home with some good messages on asthma, the differential that you brought out beautifully, Miguel. So I'll just come across to my case now. So this was a 21-year-old girl, and I don't know how often you see this, John and Miguel, but we see this often. She's a 21-year-old girl who was coughing and wheezing for the past 2 weeks, and by her primary care physician was prescribed a syrup which contained a couple of syrups actually, which contained mixtures of ambroxol, dextromethorphan and terbutaline that would give her relief for some hours. And when she was very bad, she mentioned she would use an inhaler, a salbutamol inhaler that was prescribed to her many years ago. She wakes up at least twice at night to use an inhaler or the syrup the past 2 weeks. Annie had similar episodes at the age of 10 and 14, and both of them responded to syrups and occasional inhaler use. One episode was pretty severe, the one that she had at age 14 that needed prednisolone, and she'd been told by her GP that she has allergic bronchitis, and Annie's spirometry, which we got done, was suggestive of moderate reversible airflow obstruction, and FEV1 65% predicted with excellent reversibility, 24% in 320 ml. The diagnosis was pretty clear to me. She had what would classify, her X-ray was normal. She needed to be told that she has asthma, childhood onset, and she needed a steroid-based inhaler. So there was no rocket science for me here, but her issues were that she didn't want to accept that she has or she would be labeled as asthma. She just didn't want to hear that. She was very worried about it. She had read a little about it, and she told me that she's managing her life quite well. So she doesn't exercise much. And she was okay with her GP calling her allergic bronchitis. This issue is what I wanted to first get across to both you, Miguel, and John. Do you see this often where someone's been treating the patient, has told them it's allergic bronchitis, they just don't want to be labeled asthmatic, and then one would say it's all about a word. How do you deal with this? And John, I'll start with you, John. Do you see this often in Scotland, or people are ready to accept the label?
Yes, Sujit, we used to see this. So there's a few things that disturb me about Annie's case. The first is I really don't believe there should be a role for oral therapy. And whilst it's easy to take and might help compliance, there's some immediate issues such as tremor and tachycardia from taking beta-2 agonists. But also potentially more serious effects. So asthma, in this case, is a disease of the lung, and it should be treated with a therapy which goes straight to the lung, and that's inhaled therapy. And I realize in some parts of the world there are different problems around using inhaled therapy, but we really have to promote this. If we don't give her an inhaled corticosteroid, then she's going to end up with an oral corticosteroid, as she has on at least one occasion. And I'm really concerned about some of the emerging evidence about the side effects from even a single course of oral corticosteroids. As a learning point, what I would say is if you've got patients who need more than 0.5 gram of prednisolone a year, 500 milligrams, then there's something not right about the management of that patient, and we have to look carefully at what's going on. But the idea about her not liking a diagnosis of asthma doesn't then help us to move on to the treatment of asthma. And I think we have to try hard to normalize the diagnosis of asthma. My wife was a primary school teacher. This is 10 or 15 years ago, and we had the same problem. And we had some enthusiastic nurses who wanted to go into school and help the children who had asthma. And in the UK, that's about 1 in 10 children have asthma. So in every class, there's 2, 3, 4 children with asthma. Go in and normalize asthma and help them to use their inhalers, to learn a little bit more about it, to know which inhaler does what, and basically to support the children in school. It was a project we did some years ago. And they eventually set up an asthma club. And once a week at lunchtime, all the children with asthma would bring their inhalers and the nurses would be with them. And people were actually requesting to have asthma because they heard this was a really cool club where they could all go and meet their friends at lunchtime. So we actually turned it around from being a bad thing to, something that was just another accepted, society, like the chess club or the football team, the asthma club, and it just became normalized. And I think that's what needs to happen here.
But in Annie, we had to really bargain with her. And finally, I said, okay, I will call it asthma and you will call it allergic bronchitis, but for God's sake, take the treatment that I'm prescribing you, And then she had the next issue, the next slide, which was, she was worried about steroids in general, anything but steroids, doc. I've heard of too many side effects. And why do I need inhalers if I feel well? Now, with moderate airflow obstruction, there was no way I was going to put her on need-based therapy for at least the next 2 months. John, this steroid phobia issue is obviously less in the UK, but if you do get the occasional patients, how do you deal with it?
Yes, so I wonder if Annie has been reading about anabolic steroids and sports people and so on. And I can quite understand why Annie doesn't want to develop big muscles and fat and striae and a beard and all the things that can happen to young girls who take anabolic steroids. So I think the important thing is to tell her that instead of giving her oral anabolic steroids, we'll be giving her inhaled medical steroids. And if we take a drug like budesonide, for instance, we know that in children it's absolutely safe up to 400 micrograms a day, absolutely safe up to 800 micrograms a day in adults. I don't think she's going to need a higher dose than that, so we can pretty much guarantee her safety. We know that from literature that goes back 20 years. So low dose of inhaled corticosteroids will avoid Miguel's point about a single dose of oral prednisolone, and that's definitely the line we have to go down.
Sure. I think that's very valid. So what I did with Annie was told her that you can take it because it's safe for young children. It's safe for Olympic athletes, as John was just mentioning. It's not anabolic steroid, and it's safe for pregnancy for all the 9 months of pregnancy. I mean, you don't get many such drugs which are safe in all these age groups and conditions. And I think she's warming up to it. And now with the data coming out from Oxford, we also know it's probably going to work for COVID as well. Budesonide particularly, which the study has just come in preprint. So it's fascinating actually how inhaled steroids have changed asthma, and the important thing I think is the communication with the patient, which I think those messages that both of you all gave are so critical. Okay, so that was just a very short case of issues that we face in day-to-day practice, and we had some great input from Miguel and John on that. I'll now hand over to John to present the final case today. Over to you, John.
Thank you, Sujit. Thank you, Miguel. I'm going to run through our third case of this session. Here are my conflicts of interest. And I'd like you to meet Natalie. Natalie is a 26-year-old who lives in Glasgow, and she works from an office running a charity. She lives with a friend in an apartment in town. And like Miguel's patients, we're in COVID lockdown, which means we can't really leave our houses unless there's an essential reason to do so. So she's working from home. She's not allowed to visit a restaurant or a cafe. She's only allowed to do limited exercise. She can go out to buy food. She can go out to see a doctor. She can't go to the dentist. She can't have her hair done. She can't see her friends. She can't visit people in their own homes. She's had asthma since childhood. She uses a preventer inhaler, ICS-LABA, and a short-acting beta agonist. And she's a good asthma patient. She comes to visit us when we need her to come. So that's once a year. And if there are flare-ups, she'll get in touch. She has had courses of oral steroids in the past, but recently her asthma has been better controlled. When she was about 18, she went to the emergency room and she told me she doesn't want to do that again. She said it felt like she was in a bath full of water with somebody sitting on her chest, pushing her head down. She doesn't want to experience that. She hasn't seen a doctor or a nurse for a year because that's about since the COVID pandemic influenced her healthcare delivery. More recently, she's been having an increased cough, some wheeze, waking at night, breathlessness relieved by her short-acting beta agonist. And like Miguel's patient, she followed her personal asthma action plan and increased her medication. So no tricks here. What's the diagnosis? Natalie has uncontrolled asthma. We're using the same checklist that Miguel's already shown you about the reasons for poor asthma control. And what we're basically trying to do is find out which of these in the purple line apply. Now, in Miguel's case, it was incorrect diagnosis. And for the sake of time, we're going to presume that as far as Natalie is concerned, we have the correct diagnosis. We have rhinitis, which is appropriately treated. She doesn't smoke, she's on appropriate therapy and so on, which leaves us with what are often the two biggest issues in understanding the reasons for poor asthma control, which is poor compliance and poor inhaler technique. So given that we're confident about the diagnosis, and Miguel reminded us that it's always important to check that, we've dealt with all the comorbidities and associated features. Is it poor compliance or is it poor inhaler technique? So like Miguel, I'm not able to see her in person. So this handsome doctor, younger than me, better hair than me, is going to speak to Natalie on the phone, and this is how the consultation went. How are you? Great, thanks. How are you? That's the problem Miguel had about his need to use an asthma-focused questionnaire. Of course, the standard reply to how are you is fine. No, the asthma. How's the asthma? Oh, not so good. What do you think happened? I think it's because I'm locked up, I don't exercise, I'm a bit depressed, I can't go out, I can't see my friends, it's all to do with COVID. Have you been taking your medication? Of course, I always do. Now, this is a feature of people who have asthma speaking to the doctor. The first thing is they want to please the doctor, and they know the doctor wants you to take your medication. So you say you take your medication even if you don't. The second one is they know what question's coming next, and they don't want to put themselves in a position of looking to be stupid, So why do you think your asthma is not controlled? Because I haven't taken my medication. Well, just take your medication then. Let's check. So what can we do? We can check a prescription record. And this is Natalie's prescription record over the last year. So you'll see she's frequently requesting short-acting beta agonists, and she's infrequently requesting her preventer medication, ICS-LABA.
How bad is this? How bad is this, John?
The problem, Sujit, is that this medication, the ICS-LABA medication she's taking, has got 60 doses in it, and she should be taking it twice a day. So each canister should last her a month. So we should be looking to see 12 prescriptions of ICS-LABA in the last year, and we're seeing nothing like that. So it is clear simply from this that she's not ordering enough medication. Maybe because she can't get out, because she doesn't want to visit the pharmacist. The systems we have for reordering medication are different just now because patients can't easily come to the practice. So there may be good reasons or there may be bad reasons, but we can see simply from this that she's just not taking enough medication. That's a very simple way of identifying whether somebody's using their medication or not. Are they ordering their medication? But there are many, many stories of patients who have ordered medication and not used it. And sometimes my nurses tell me they visit older people at home, and when they open the cupboard doors, all these asthma inhalers fall out. And the reason is they keep ordering the medication, but they don't use it. So there's some very interesting new work going on around connected e-inhalers, which are hopefully going to help us to work through this problem. And there are two currently licensed in some parts of Europe, North America, the Western world. One comes from Novartis and one comes from Teva. And these are electronic devices inside inhalers, which are now licensed. And the devices actually look very similar to, almost identical to devices we already have, which measure the timing and the performance of a person using. I'm going to show you some data from this one, which is a prototype, which isn't licensed, but is being used for clinical studies. It's called the INCA inhaler. The INCA stands for Inhaler Compliance Assessment. It's one of these acronyms where you have to take some of the letters from the phrase and put them together. So this is Inhaler Compliance Assessment. And this team from Dublin, Richard Costello's team in Dublin in Ireland, have done some very good work. And these are the kind of results that they get. So on the left, you'll see somebody who is a very, very frequent short-acting beta agonist user. And on the right, you'll see somebody who's a very poor user of inhaled corticosteroids. And if we get it right, then we get this kind of pattern. And this is a patient who is regularly taking their medication twice a day. And the yellow dots is poor inhaler technique. Now, these devices all use different mechanisms to assess inhaler technique. The INCA device, the one I showed you there, the one from which this data comes from, uses a microphone to assess inhaler technique. The Teva device, which is the one I'm most familiar with, measures the pressure drop when the device is used to assess whether the dose has been taken correctly. So these devices are becoming much more available to us. They're not going to be particularly cheap, but if we're looking to try and identify true inhaler technique and true compliance, they're going to be very useful.
Oh, just a question here, John. I find it challenging for patients to use such complicated inhalers. Patients with asthma want life simple. So how often do you see inhaler technique as an issue in clinical practice? I mean, how?
So the first thing is that the latest e-inhalers actually look like the inhalers patients currently have. So we overcome that problem. And I think one of the things that we clinicians are going to have to do is ensure that the enthusiasts for these devices don't overwhelm a patient. But if we forget about e-inhalers for a while, you're quite right. The problem is that we don't check inhaler technique often enough. And we maybe as a second, I know this doesn't apply to you, Sujit, but some of your colleagues maybe in the UK, secondary and tertiary care physicians, hope that somebody else will do that, like the general practitioner or the pharmacist or the nurse. But the only way you can be sure it's done is by doing it properly. And when I run my secondary care respiratory clinic, I annoy the staff sometimes by spending so much time trying to explain to patients how inhalers work and making sure that they can use it properly. You'll see that in January, she started to order up more inhalers. She's recognized something had been going wrong. So for some weeks now, she's identified by herself her compliance issue, and she's addressed that by requesting more and more inhalers. So if she's using more inhalers and she's not getting better, could that be because her inhaler technique is poor? And this comes back to your question, Suchi. Using an inhaler is not like riding a bicycle. It's an old English phrase. If you learn to ride a bicycle, you'll never forget. I don't know if that applies in Spain and India, elsewhere in the world, but it's said that once you can ride a bike, you never forget. An inhaler technique is not like riding a bike. It's more like my golf swing. And I have to practice and practice and practice and practice, and I have to check. And when my patients come back, I have to check their inhaler technique is still good, because inhaler technique decays over time. So you have to remind them and teach them again and keep improving it and keep it going. It's not like riding a bike.
Each and every day we are teaching our peers, health professionals, nurses, residents, specialists, even secondary care people, And
Sure.
what we see is that they don't know how to use the inhalers. And that's a big problem. So you cannot teach something that you haven't learned.
Excellent. No, I think that's so true. And I think the message goes out that never assume your patient is taking the inhaler correctly. And so what we have started doing is check. Everyone doesn't have the luxury of an educator or a nurse practitioner, in their practice, but at least get someone outside your clinic to maybe check how it's being taken before you consult the patient, so that you have one thing sorted out before you move on, and don't assume your patient is taking it correctly, even if he's been your patient for the last 10 years. I think that's the message that's clearly coming across. John, please continue.
My final slide is the learning points. And these, you might come across any one of these three words to talk about the issue of not taking medication. So please be assured that unless you've got very good knowledge, very in-depth knowledge of English, the words are pretty much all interchangeable. We should always be looking for adherence in poor inhaler technique, because very few people are fully adherent. Most people don't have excellent inhaler technique, so we need to address those at each and every consultation with our patients. But the patients won't admit to these issues because they want to please the doctor. And one of the reasons I went into medicine was because I recognized there was an art to it as well as a science. So it's not just the knowledge, your knowledge of the lung deposition of a particular device and the therapeutic effect of that drug. It's the skill of persuading a patient that they need to take this medication. This is how you do it. This is why you do it. This is how you're going to be successful. This is how I can help you lead the kind of life you want to lead. So I think we need to come to an understanding with our patients about the requirement for regular medication and understanding of asthma and its treatment. And we have to look at these two very common issues at every consultation to make sure that we get the best care for our patients.
Thank you both very much, really, and I cannot thank you all enough for those excellent cases and the discussion we've had. We have a question now that's coming in and from other countries, and so I will put the first one across to Miguel. What is cough variant asthma, and how is it best managed, Miguel? What's your take here?
Well, cough variant asthma is it's just a type of asthma that is mostly affecting in one symptom, that is cough. So asthma normally gets you wheezing, gets you chest pain, gets you dyspnea, and for this variant of asthma, you only have cough. So this makes a big problem because it's difficult to diagnose, because when you have in front of you a coughing patient, you have to exclude other causes, and sometimes if there's no dyspnea, if there's no wheezing, you leave asthma in a second stage and you don't think of it in the first stage. Right. The good thing is that cough variant asthma is asthma. So it's an eosinophilic inflammation in the lungs. So the good news is that it responds absolutely well to inhaled corticosteroids too. So sometimes when you see the chronic cough guidelines, how to treat chronic cough, then you have to treat reflux, gastroesophageal reflux. You have to treat the nose, take a look at the nose, see if it's polyps or rhinosinusitis or so. And then you also check if this asthma, and the easiest way to do it is with a trial with inhaled corticosteroids. Yep. And if they work, because you are not going to make a bronchial biopsy to the eosinophilic inflammation. So maybe it's as easy as that, to make a trial with inhaled corticosteroids and just check and take a look at what happens.
Sure. I think that makes complete sense. And I think it's again labeling the patient correctly, treatment largely the same. The next question is to John. Montelukast. How do you rate Montelukast efficacy in chronic asthma management? Because it is used a lot, John. I don't use it personally very much, but your thoughts?
Yeah, so Montelukast is used differently in different parts of the world. It's used rarely in the UK, but it's quite a popular treatment in the USA, for example. And one of the reasons it's popular is because it's a pill. So that gets around any issues around inhaler use, poor inhaler technique, and so on. But most of the studies show that in general, it's not as good as using low-dose inhaled corticosteroids as the first preventer. So there's obviously some patients who get some benefit from it, and it's purported to be useful in patients who are principally rhinitis symptoms. But our experience and our data analysis is that it is not the best option for the first treatment of asthma, which is inhaled corticosteroids. So there is some use of it as an add-on therapy. So once we've used low-dose inhaled steroids, high-dose inhaled steroids plus long-acting beta agonists, it's sometimes worked as an additional fourth medication. But it's not something that's widely used at all in the UK now because it's felt that its benefits are minimal and there are better treatments for asthma than montelukast.
So the next question comes to Miguel. When is it possibly correct to step down therapy for asthma?
Well, guidelines criteria is when it's 3 months with no symptoms, when it's 3 months that the patient is controlled, you can step down. But this is guidelines. I don't think John, even myself, and not even the whole doctors community in Spain or in England, they make that because first you are scared of a flare-up, especially when the asthma patient is severe, and then the inertia, we have this inertia of not changing medication. This can be good or this can be bad, but this is the reality. It's one point that I always say when to step down. It's easy to step down, for example, in Sarah, that was 2 puffs twice a day and say, okay, 1 puff twice a day. That's easy to step down.
Right.
You have another easy step down when you are with the same drug. The problem is the step down when we go from a combination therapy with a corticosteroid and a LABA to a long corticosteroid.
Right.
Because then you lose this bronchodilator response and you can lose first the adherence to medication because then the corticosteroid I don't feel it, so I don't take it. And then of course you lose the effect, the efficacy of the pharmac. So difficult to step down, but normally we should, because at least to go to the less inhaled corticosteroid dose possible.
John, the next question comes to you. Steroid non-responsive asthma. As a primary care physician, if you have a patient who's not responding to an adequate dose of inhaled steroid, what's the ideal next steps?
So I'll try and guess the scenario you described. So if we go back to our reasons for poor asthma control, let's check that the diagnosis is correct, the inhaler technique is correct, the adherence is excellent, the rhinitis is dealt with, the smoking, the patient has been counseled to stop smoking, has indeed stopped smoking. Then we're left with inappropriate therapy because of a particular phenotype. So in the past, these patients had very few options, and a common option was to put them on oral corticosteroids, which is something we now very much want to avoid if we can. And we're fortunate now to have a range of biologic therapies which have become available. And these again may be limited in some countries because of the expense of them, but we have anti-IL-5s, we have anti-IL-4/13, we have omalizumab, which has been around for 10 years or more now. And these are potential options for selected patients. So if the patient is genuinely steroid resistant, we need to be very clear that we had the correct diagnosis, and we need to work out if they had type 2 asthma. So we would be interested in their eosinophil count, their FeNO levels, and so on. And then we would have to consider non-steroid biologic therapies to assist them.
That's a very important message that all physicians should take. Check technique, check regularity, adherence, and then only go down the line of adding new drugs. Super. The next question, and the final question that's come in, is to Miguel. There's a bit of concern about the incidence of pneumonia with some inhaled steroids, I think especially fluticasone. Your thoughts, Miguel, and is there a personal preference you have here?
Yeah, absolutely. So corticosteroids are anti-inflammatory drugs. They can cause some kind of immunodeficiency in the bronchi. And we have data, we have a lot of observational data, and of course we have data from the randomized control trials that say that they increase the pneumonias.
Right.
Mostly, I think, in my personal view, we know that, and we have to live with that. So you cannot leave an asthma patient with no treatment because the risk of pneumonia. That's a stupid thing. Okay, so there's no way to do that because pneumonia can happen once. It's easy to cure, and asthma is there for the whole life, and it will take attacks and maybe hospitalization and even mortality for asthma. That is still there.
So thank you ever so much, both John and Miguel. We've had a fantastic session on challenges that physicians face in day-to-day practice in asthma, with some asthma mimics, communication issues, and the merging of the art and science of medicine to help physicians manage asthma better. I'm sure there have been a tremendous amount of great take-home messages. Can't thank you all enough for your time. And thank you, the audience, for being with us till the end. I look forward to welcoming you to episode 6. But before that, I'd like to thank our collaborators, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPATH from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. Thank you ever so much to all these societies for collaborating with us for episode 5 and to be there with us for episode 6, which will also be on some challenging cases, again related to asthma. Look forward to seeing you there. Thank you.